we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions, a variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. Over time, we face a variety of feminine conditions. Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. To its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, of changing treatment for a wide variety of common feminine conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, FemiLift is safe, quick, painless, and minimally invasive, providing real and immediate results. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, FemiLift is safe, quick, painless, and minimally invasive, with real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about FemiLift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Years of experience in laser aesthetic medicine, FemiLift is safe, quick, painless, and minimally invasive, providing and immediate results. It's time to reclaim our inner joy and enjoy our femininity to its fullest. To learn more about FemiLift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions, providing real and immediate results. It's time we reclaim our inner joy. Over time, face a variety of feminine conditions. As a result, we feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic, safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its full. To learn more about FemiLift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, FemiLift is safe, quick, painless, and minimally invasive, providing real immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about FemiLift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Lasers' 15 years of experience in laser aesthetic medicine, FemiLift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy, enjoy our femininity to its fullest. To learn more about FemiLift, please consult your doctor. Over time, we face a variety of conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions, based on joy and femininity to its fullest. To learn more about FemiLift, please consult your doctor. Alma Lasers' 15 years of experience in medicine. FemiLift is safe, quick, and invasive, provide real and immediate results. It's time we reclaim our inner joy and enjoy our femininity. To learn more about FemiLift, please. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. FemiLift by Alma Lasers is a life-changing treatment for a wide variety of fullest. To learn more about FemiLift, please consult your doctor. Time, we face a variety of feminine conditions. As a result, we may feel embarrassment. Is a life variety of common feminine conditions, based on Alma Lasers' 15 years of experience in laser aesthetic medicine. FemiLift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult a doctor. Over time, we face a variety of feminine conditions. As a result, we feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femileft by all lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about please consult your doctor. Over time, we face a variety of feminine conditions. Feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time we reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please consult your doctor. Over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Laser's 15 years of experience in laser aesthetic medicine, Femilift is safe, quick, painless, and minimally invasive, providing real and immediate results. It's time to reclaim our inner joy and enjoy our femininity to its fullest. To learn more about Femilift, please over time, we face a variety of feminine conditions. As a result, we may feel discomfort, pain, and embarrassment. Femilift by Alma Lasers is a life-changing treatment for a wide variety of common feminine health conditions. Based on Alma Femilift, please consult your doctor. Over time, we face a variety of feminine conditions.
Amongst ourselves. till Dr. Ronan is just having lunch. He just went for a round and he just come back. And I would request till Dr. Madhusudan also joins us for the next talk. And we have some surgery videos then. But we'll go on a general management of what, how we manage women incontinence. And I would request Dr. Anurag, please join us here. Just to answer some queries of this, Dr. Amit Tandon, please join us here. Dr. Ashwin, who will join? Anyone? Urology cases ज़्यादा देखते हैं urogyney? Yeah, how you treat? Or you can answer from there only. So guidelines on how urinary incontinence in women are or should be managed. So first is a general question. Amit, what is urinary incontinence? I mean, people want to know ki kya, I mean, because you are asking some questions, how do you?
Incontinence, what we normally see in the general population, can be divided broadly into two. One is urge incontinence. Patient कहता है कि मुझे पेशाब लगती है, मैं रोक नहीं पाती हूँ. So that is the one of the most common complaint the patient comes with. And second, what we see in the population is stress incontinence. That is, whenever patient is rising, coughing, sneezing, she passes few drops of urine. So these two are basic two types of incontinence which we see in the general population. So stress incontinence can be further divided into a
So
urine.
we'll just come to that.
Yeah.
Let's Dr. Anurag, how do you feel? Women come more to you with incontinence or men come more to you? As a urologist, what do you see?
Yeah, we see both.
Do men have urinary incontinence?
Yeah, we have both kind of patients, men as well as women, who complain of incontinence. The little difference in our cultural scenario as compared to the Western is that we bear with it, and we have been taught from the very beginning to bear with everything we bear in social life. So our patients do not usually complain, and ladies, I'm sorry to say, they just
Bear with it for a very long time. So it's
For a very long time.
social and
yeah,
psychosocial
they just
problem.
don't complain, and they think it is a norm of life with aging, with childbirth, and it happens with childbirth, but they think it can be corrected. So I as a urologist see both kind of patients, females and males.
So what do you think? What are the types? Because इतने सारे अभी बोल रहे हैं, what types of incontinence?
Yeah, both. I mean, we have a lot of mixed incontinence also.
So you have stress,
Yeah, urge and mixed incontinence.
urge, and mixed. Overactive or functional incontinence, what we say.
Yeah, both.
Overflow incontinence.
Overactive bladder is mostly urge incontinence. Urge is the word given for the feeling that the woman has. But overactive bladder can be dry or wet. So wet is the urge incontinence. Overactive bladder dry is somebody who can tolerate. He has a lot of frequency and urgency just because of the high pressure produced by the bladder. Frequent.
Urine at the external urethra also. Men cannot control at external urethra.
No, not really.
So
No, no.
I think internal
No, it is not like that.
or
We
because men once the internal sphincter
Yeah.
leaks, it has to leak out.
there are two sphincters. Men have a strong internal sphincter as well, which is called bladder neck, and which is fortified by the presence of prostate. So they have the urine stopped at the internal sphincter also. External sphincter is something which
Men
is
don't have any external
voluntary.
sphincter.
No, they have.
They have.
Everyone has. The perineal muscles is what is external sphincter.
Yeah.
There is nothing else external sphincter. The perineal muscles, the transversus perineal muscles, they are the external sphincter, and they are under voluntary control. And they, the cough or some other thing, the external sphincter reflexly contracts and produces more resistance. Yeah.
Any one of you can ask any them questioning. So Dr. Amit, how do we, if the patient comes to you, how do you investigate? What is the initial assessment? How and when? What all do you do? How should we go about it?
The first and foremost, the patient comes, a general examination has to be done. That is most important is urine analysis of the patient should be done. We should rule out infection. We should rule out the diabetic status of the patient. We should rule out whether the patient is on antihypertensives which is causing excessive urine formation. That is the primary workup. After that we can get ultrasound done. Ultrasound means we ask the patient to hold the urine as much as she can, pre-void and post-void. After she passes the urine, again we get an ultrasound done.
We have to see whether the patient has frequency alone or frequency and urgency both. We have to see whether the patients are diurnal frequency and urgency or a nocturnal also. There are patients who are largely functional in their symptomatology, and then these patients will have no nocturia and no problems at night time. They have mainly diurnal problems. So we have to look into that also. Some of them are having polydipsia, not necessarily because of diabetes, it can, or diabetes insipidus, but maybe psychological, or you can call it compulsive polydipsia, which is a part of obsessive compulsive disorder.
So drink too much, so they'll definitely.
Yeah.
What do you think, uroflowmetry is required in
Yes,
women?
yes.
Men to prostate obstruction?
No, no. In
women?
females also, uroflowmetry has a good role in defining the obstructive patients, because urge incontinence can be because of obstruction also. As a response to obstruction in the outlet, the bladder has to contract more. It becomes hyper. Again, it can be functional because of a tendency to keep the external sphincter tight, which again neurological or non-neurological. It can be a learned faulty toilet training in which at the very beginning the child is taught to hold, to keep the sphincter tight till there is a natural place to void. So at times we develop a kind of dyssynergia between the external sphincter and the bladder. The bladder is contracting and the sphincter is not relaxing. Usually the synergistic movement is the bladder muscle, that is the detrusor, contracts and the external sphincter relaxes at the same time. In some patients, also in spinal trauma and also in faulty toilet training, we have a tendency to contract the external sphincter while the bladder is contracting. These patients have obstructive flow. So uroflowmetry is important to rule out obstructed patients, because unless you treat their obstruction and you treat their symptoms, they may become more obstructive.
So do these patients first, do you advise them some change in lifestyle?
Yes.
For problems?
Yes, we have to tell them relaxation techniques, and some fluid intake has to be more. If they are drinking a lot, they have to be,
like
it has to be
polydipsia, so you have to tell them itna pani nahi pina ya zyada
yes,
nahi pina.
yes, and we were talking about the voiding diary. That's very important, because some of the patients think they are not drinking much, or they say that since the urine is coming out so much, my body needs it, so I am drinking. So it is a question whether the hen came first or the egg came first. We say, why are you drinking so much? Because you're drinking, that is why you're having frequency and urgency. Patient says, since it's coming out, I have to drink. So that is the problem. So we have to tell them about the bladder diary. They have to keep. Once they start taking a note of whatever fluid they have taken out and whatever urine output has come out, it's a part of treatment also. They make the bladder diary. With a look on the bladder diary themselves, they realize that they are drinking too much. It's not needed. Similarly, the bladder volumes, the output that it's coming out, if they see that they are avoiding only 50 ml or 100 ml every time, they themselves understand, why can't I hold a little more? So bladder diary is very important.
And obesity, obese women, obesity has any role obese women are more prone to develop incontinence, or?
Of course, obese women, they are more prone to develop especially stress incontinence.
Stress incontinence. So that has to again be kept in mind.
Kept in mind.
Weight loss is also one of the important
lifestyle.
So how do we medically treat it? Have we treated medically?
Yeah. So
anyone comes with anything, we write Doloxetine or something like that.
Yeah. Depending on what symptoms we find in the pre-monitoring, if we find the patient is having a predominant stress incontinence, so two treatments which have proven therapy before we go to the surgical treatment, or the patient is not willing for surgery, she feels doctor पहले आप हमारे दवाई से control करो तब हम surgery के लिए सोचेंगे, lot of time. So one is local estrogen application and second is duloxetine. These two drugs have their efficacy, maybe in mild to moderate cases.
Anurag, we should try duloxetine in all of these because it is said to treat mixed also, urge and stress also. So
No,
can we give a trial of duloxetine to all?
Yes, we always give duloxetine trial before subjecting the patient for any kind of surgery. And duloxetine, initially we give 20 BD, but it can be increased to 2 BD, 40 BD, and even 60. So if the patient tolerates, duloxetine can be increased, and it really helps in addition to Kegels. So exercises and duloxetine, both are very important.
Exercise, pelvic Kegels exercise very difficult to teach. हम लोग बहुत tight curls करो, वैसे proper Kegels exercise should be taught. I think it's not
Need
a
a good physiotherapist to really
should be
make the patient do it practically.
practically so. What would be the next step? Medical treating, how do you decide whether they need surgery and what type of surgery you should do?
Yeah.
Should you do tape? Should you do bulking agent? Should you do colpo suspension?
Yeah.
Or should you make an artificial sphincter?
Yeah. So once we are sure that the patient is having stress incontinence, then we elicit a response. There are two tests, clinical tests. Urodynamics, if you have a facility to do, that's excellent. Even if you don't have a facility, it's not compulsory to do a urodynamics before we take a patient for SUI surgery. So there are a couple of clinical tests, Boney's test, we should always try to elicit in the OPD to see whether what kind of stream the patient is throwing when she is having stress incontinence. If she throws a good amount of urine, it means that she is more of a patient with urethral hypermobility. And another kind of urine, she has a spurt just falling outside the urethra. That shows that she has a more intrinsic sphincter kind of a deficiency. So patients who are having a urethral hypermobility, they are bound to respond well with TOTs and TVTs.
So patient lays in the stirrup, you put a posterior speculum, you ask her to cough, be careful. If it is neck, the whole urine will come on your face. So that has been seen with these videos.
Obstruction. So first thing is that you have to rule out any obstruction, and this is more common in men because the patient is having obstruction due to prostate and his bladder as a result has become hyperactive, and he presents only with urgency, and you think it is just urgent continence and you start bladder quiet. And these medicines are called anti-muscarinic drugs, and the most important ones are sorifenacin and tolterodine, derifenacin and other medicines.
Again, tolterodine, lot of us तो toltor मिल रहा है, फटाक से लिख दे 7.5 have it.
Derifenacin.
So that is a lot of us use it for first line for any patient comes with incontinence, toltor लिख दो.
Most patients have a combination of urge and stress incontinence.
So it takes care of the urge, which is more problematic, I think.
So you have to take the history. If the patient has urge or she has just, she wets and then it comes to. And by the way, I would like to remind of some patients who actually have an anatomical incontinence like post-hysterectomy. So post-hysterectomy, ureterovaginal fistula or vesicovaginal fistula are common. Only 2 days ago, I saw a patient who had hysterectomy 8 months ago and was being treated as stress incontinence. It is very common. If the patient goes back to the original surgeon, it's very likely that she will be labeled as stress incontinence and being treated as that. She went to a big exam that vesicovaginal fistula was missed and it was picked up only by cystoscopy. So all post-hysterectomy patients are not stress incontinence. One has to rule out fistula.
So that is very important. Very small fistulas might be just leaking
so
a few drops sometimes.
Yeah, small fistulae and ureterovaginal fistulae will have a normal voiding pattern also. Patient says, I can pass urine. Blood fills. Since the leak outside is less than the rate of formation of urine, the bladder keeps filling. We are not talking about a large 2-finger, 3-finger fistulae in which bladder never fills. It's found always empty and patient found always wet. There are fistulae which are very small. Similarly, ureterovaginal fistulae, because the other ureter will keep on feeding the bladder. So bladder is filled, patient is voiding in stream, and we miss that this could be a fistula also.
And desmopressin, these drugs or better drugs?
Desmopressin is to reduce the urine output. This is for any kind of frequency, urgency and incontinence when the urine output has to be reduced, especially at night time. So it is available as Minirin, but it's not the first drug of choice. We have to see whether it is stress or the urge incontinence, and the first drugs of choice in both these, in urge it is like solifenacin, darifenacin or tolterodine, and in stress it is duloxetine.
So this is how we should plan the treatment, medical treatment, not give whatever drug. See, most of the problem is that urogynecology is now specialized.
Yes, yes.
So most of us are doing obstetrics or things like that, and we rarely, I admit as a gynecologist, even I paid a very less attention to this urogyne field till now, till recent, when I thought this problem is actually too much, and we should have a thorough knowledge about it, and we used to write whether अरे वो रह पाया था उसने कहा स्ट्रेस मिस्ट इंपॉर्टेंट टॉल्टोरिन, तो सबको वो लिख देते हैं, और ये उसने कहा था नहीं काम करेगा तो डेस्मोफिन मिनीप्रिन लिख दो ये. So that is how we are guided by a lot of times by the pharma driven, so that we have to understand what is wrong, and that so clearly and beautifully said that what was wrong. So these are some of the surgeries which you can also plan, or procedures which are not very invasive. Do you think these work?
Yeah, they again are the last resort things.
Botox injection, Botox we use now, Botox is
and also for overactive bladder. Again, as I said, overactive bladder is something in which the bladder is contracting too much with higher pressures than the body can or the external sphincter can handle. So the patient leaks. So if you inject botulinum, which relaxes the muscle, which actually paralyzes, same as it does on the face. So it paralyzes the detrusor muscle. You have to give injections at 20-30 points in the bladder, but it works again for just 6 months. So one has to be careful whether it will be a permanent solution or not.
So कैसे करते हैं? Cystoscope से through अंदर
Yes,
से देते
yes,
हैं?
there is a special needle for that, and you go in with a cystoscope and over the bladder at different points, 1 centimeter apart, at several points, you just inject, and that paralyzes the muscle, and the patient got rid of that repeated contractions of the detrusor. This can be done in neurogenic also, not only in functional patients.
Overactive nerves are acting more, so you have to paralyze the nerves.
You paralyze the muscle. So that urgency repeatedly.
Like all Botox on your face and all to get that. So when should we refer the patient to a urologist? I mean,
actually,
should we refer or not to refer?
Yeah.
Let's see the gynecologist point of view and let's see.
Yes. I think referral to the urologist is when, in spite of giving medical treatment for detrusor overactivity, the patient is not responding, or the patient's had for sufficient time, and you want to get rid of the patient. So
I tried with that patient for 2 years. I sent her to everyone, but finally she ended up getting a atrophic laser done today. Let's see if it works. And of course, if there is frank hematuria, then they need to establish where it is coming from. So it might be a bladder tumor, it might be injury, it might be from the kidneys, wherever it is coming. What do you say? When should we? What is the synergy between a urologist and a gynecologist?
I think
or should we have special urogynecologists?
No, I think all the female patients first go to gynecologist, even for their, stone or anything. So they should go to a gynecologist. They have
gynecologist is more like a family physician, because we've delivered babies. They can talk freely about their life.
But sadly, they also just see the reports or just take the history without actually examining. So
I agree. That is what I'm saying. That is a clear guideline.
The patient has to be examined. That's important. And a urologist also, when he sees the patient, if the patient is unwilling, would send to a gynecologist just to rule out actual problems in the vagina on examination. So, and if the gynecologist again starts writing some medicine without examining, then it's not good. So the patient goes to gynecologist, If the patient is not getting relieved, then the patient comes to urologist by being referred or on her own. But urologist should see all patients who are actually obstructed. They may be taking treatment for infection when there is none. And again, here I would like to remind all of the audience that we should do a midstream urine examination, which neither the pathologist nor the clinician tells the patient, and patients may be having 10 reports, must have taken 10 types of antibiotics without a midstream urine, and when I ask for a midstream urine, the urine is normal. So there is no UTI in which there is no cystitis, in which there is no dysuria, no pain, nothing, only pus cells, and patients are being treated with high-end and injectable antibiotics for this kind of thing. So
asymptomatic bacteria should not be treated.
No, yeah, but the actually prove that there is bacteria or pyorrhea.
That has.
If you take midstream urine,
so if you see pus cells, 5 to 10 pus cells, 20 pus cells, most of us write very high-end antibiotics.
Yeah, this should not.
But if you see bacteria in it or fungus in it or whatever, then there is a picture.
Yeah, sometimes we need to take a catheterized sample. We just take a small feeding tube, put in, let some drops come out, and then take the sample to make sure that there is no infection inside. There can be urethral infection or vaginal infection which may be giving.
Idea to take midstream is urethral is washed out and you actually getting a bladder sample. So that is the idea for midstream. And if you put a catheter also, let the first, because the catheter is going in, so that should drain out, and then the midstream should be after a little bit of urine is passed out. So
and urethral obstruction is not uncommon in females, in especially elderly females with the senile vaginitis and hypoestrogenemia. Urethral stenosis is found very, very commonly, and we see patients who have chronic
urethral syndrome.
No, urethral syndrome. Urethral syndrome is different, and we find uremia just because of urethral stenosis, which has been missed for years. So always, if you want to analyze the urethra, pass 14 French.
Put in a feeding tube.
Feeding tube may go. Feeding tube is a small thing.
Or a catheter, normal catheter.
If a Foley's catheter of 14 French goes, there is no stricture worth the name. So if it goes, then there is no stricture.
Then that would be. So all these when you actually suspect, so you should know the urologist is your best friend here, because he is more trained to look at that. And we have to do a per speculum. You have to look at first degree prolapse. You have to look at the cystocele, rectocele. If we don't see, they also don't see. Kya per speculum kya karna hai? Symptoms pe likh denge, diary pe likh denge. So that makes it treatment uncondemned. And a routine referral to a specialist OB/GYN who does this, or a urogynecologist who is there when there is a specific problem of the genital tract. With that is, you are seeing that the bladder is prolapsing or the uterus is prolapsing. Then they have to go in for that specific person. So you consider referral when there is persisting pain, when there is clinical masses, when there is fecal incontinence along with it, when suspected neurological, voiding difficulties, suspected fillers, previous continence surgeries and previous pelvic surgeries or radiations. Now these are the group which will need specialized care and a specialized treatment with a specialist who is more prone to think that way. We also can think, but we are thinking 10 different things at the same time. So that a general gynecologist may miss it, a general stone urologist may miss it. So that this is where some special uro clinics should be. Catheterization, as he said, yes or no at all of these. He just so beautifully said, post-void urine, if there is destruction and you have to rule out whether the urethra is constricted. And 14 number you said?
Yeah, 14.
And you can do it in the OPD?
Yes. Calibration, you just calibrate. If the urethra is 16, means 14 goes easily, that minimum the urethral size is 16. If the urethral size is 16, then there is no actual anatomic problem. There can be a voiding problem because of functional action, but not stricture.
So here is your quiz. A continent woman, number 1, normal. So you have to tell me what is number 1 out of all these. The lights were what is in number 2? Because if it's abnormal, cyst. What will be number 2? And if it resolves, if it is abnormal, then what will be number 3? Out of these, the choices are here, A, B, C, D. And if it is predominantly stress, then what is it which she does not get better in what you should be doing? And predominantly 5. So number 1, who is going to take this quiz? So this is for you all. What is here out of these words? Incontinent woman, what do you do to classify between normal and abnormal? Out of these, the choices are here. And then if she is abnormal, treat it, it gets resolved, then what do you do out of these?
I think one should be
So one is G.
If there's no infection, then 2 means.
So that midstream urine examination is number 1, what he so clearly just said. Now if it is normal, then the second one is N.
What is N?
He goes for lifestyle modifications. That would be. Number 3, if it resolves after treatment, then it is treatment if it's infection. If midstream urine has shown pus or an infection or bacteria, you treat. Then she just needs reassurance, nothing else, nothing more than that. And then if it's after 2 weight loss, then you say it is either stress or it is urge. So if it is stress, it is H, then PFE. And if it is predominantly urge, it is anticholinergic agent. So there is a medical treatment. And if she does not get better, then finally you have to go in for a good friend, then they go to Dr. Anurag Yadav. Okay? So that is how we should be planning our urology workup of an incontinent woman. And that will lead us to handling all of them scientifically and handling all of them quite nicely. So we are going to put this presentation. Don, he's come here. He's having lunch. So now we can have questions till he says video.
There's a question from the audience.
Yeah.
You can combine both. You can combine both, but to give too many medicines, you will not know whether the patient improved because of this or that, when to stop and what to stop. So give one. If you are sure that this is stress incontinence, start with exercises. If you are sure this is urgent incontinence, then you can give derifenacin, solifenacin or tolerdine. Yeah, if you are sure it is this, then you can give both. Yes, you can give both. And you can give the smaller doses and then increase.
How long can we give these drugs?
No, very long. The stress incontinence will improve with exercises over 6 months' time. Weight loss and exercises. It will take many months. So during that period, you have to support by giving duloxetine, and you can first increase the dose. When the patient is fully well, then you can decrease the dose and give a maintenance dose. And urgent incontinence also, you can keep for long. These medicines can be given for months. Pardon? If there is a background cause which is causing urgent incontinence or stress incontinence, then yes. And there are patients who complain of stress incontinence only when they develop cough. So they are all right, but they have cough and or the cold, and then they sneeze and they complain. Or during winters, outflow also becomes less. They go less frequently to the, so they don't complain. So these are things better with time also, and exercise is very important.
About stress incontinence, I was talking. There are 2 kind of surgeries which we do. One and this transvaginal tape, TVT. TOT is more for patients who have ureteral hypermobility, and TVT is more for patients who have intrinsic sphincter deficiency. So if the symptom is more pronounced, we should go for TVT, and if it is less, we should go for TOT. But if you're having a patient of hysterectomy with which you want to do a stress incontinence surgery, it is Birch Calper suspension. Initially, all these retropubic surgeries were being less popularized because of incoming of TOT and TVT, but now studies have found that when nothing works, T works best. The Birch Calper suspension works best. So a lot of patients who have intrinsic sphincter deficiency, who don't respond to TOTs, they respond very well to lateral wall suspension procedures, suspending the lateral wall of vagina to the white line and doing Birch Calper suspension.
And then there is a group of patients who have actually obstruction and they have a full bladder, they are in chronic retention and they are leaking. So at this time we have to improve their voiding and not to relax the bladder further. So the patient comes that I am incontinent, and what without gives is those two medicines which will further worsen the situation. To see whether there is a
what is the cause of urethral strictures in women?
It is more common than we think, and maybe in my practice I see many of them.
Infection, tuberculosis?
Mostly it happens in elderly hypoestrogenemia. So urethral, like vaginal stenosis or senile vaginitis, urethral stenosis also occurs. Some can relate it to a catheterization episode in the past, and there has been a traumatic catheterization or traumatic removal of a catheter, or some kind of reaction with the poor quality material of the catheter. It happens in men, it happens in women. We treated, I personally treated with Otis urethrotomy. There is an instrument called Otis, which it dilates as well as cuts. In the past, we used to do just dilatation. So people have been doing dilatation without anesthesia, in which case you cannot go very high, maybe not beyond 30 frames, but people used to do dilatations under anesthesia. At that time you can have a look also, cystoscopy and a dilatation. But this is only temporary. If the patient actually has a narrow urethra, which you can say,
seeing these patients coming again and again,
they need dilatation follow-up. Yeah, they do need dilatation.
Because our parents were doing simple dilatation, that is what we...
That stretches only, that does not cut the narrow area. And if you stretch strongly something and it produces several cracks radially, it heals with further fibrosis. So cutting cleanly at one point gives a good result.
Better result. Oh. Another thing which we see most commonly is patient having pulses, but culture is sterile and symptoms are there. So I think this is a common problem all of us must be facing. Recommend what should be done for that.
First thing is a midstream urine, that this is possibilities of those organisms which are not routinely put to culture, like ureaplasma, mycoplasma, or fungus, or tuberculosis. So if the patient has symptoms as well as pustules, you have to investigate for all these. Yeah. Yes. So, yeah, there are two reasons for this kind of urge incontinence. One is neurological. She may be having something in the spine if she has this. So we have to look for neurological checkup. If there is no neurological found, then neurological means there can be a spinal tumor or anything. There can be spina bifida. If we investigate for neurological cause of incontinence. Urge incontinence means, in this particular case, a strongly contracting bladder, which the patient cannot inhibit, and the patient cannot stop the stream by contraction of the external sphincter. So it comes out. So this patient, why her bladder is so strongly, whether there are some nerves coming from the spinal cord which are doing this, and not, in fact, the normal voiding pattern is to inhibit the normal contraction. in young age and in elderly, sick patients, very, very old, we see that the patient is passing urine in underclothes. Why? Because they have inhibition. Normal starts from the brain, and there is an inhibitory influence which develops in the spinal cord with time. When the child is born, he passes every 5 minutes and without any inhibition. Once the spinothalamic gets myelinized, the child starts walking. By that time, the inhibitory influences come. So inhibition is lost in this case. This could be neurological. Suppose this is not neurological, you have examined and investigated completely, then this is likely to be faulty bladder training. One, in the past, recurrent urinary infection. Because urinary infection that happened, the child pain urinating, that she learned to contract her sphincter, trying to urine. If the urination is the sphincter, so this becomes a habit over time. So past history of urinary infection can have this. So the bladder more external sphincter is more long way of time. These contractions happened because the child was hold. Don't go, you have to, don't wet your clothes. A mother which is very, very Hitler type can produce this kind of response in a child, male and female both, that the child learns to contract the sphincter when there is a nature's call, which is against the...
Mother says that she never had proper bladder control. It is worsening day by day, but she never had proper bladder control.
Likely to be neurological, MRI, lumbosacral spine MRI. There is a bowel symptom also because S3, S4 segments for lower segments for the urinary control, and they are for bladder and bowel both. So if there is bowel problems also.
No bowel.
Another reason for urinary symptoms in children is constipation. Only constipation, no urinary disorder can produce lots of urinary. You treat constipation, the urinary symptoms will become all right. This is called evacuation syndrome or elimination syndrome, in which both are involved, and mostly the culprit is bowel. Will have lots of and he or she will go to the toilet very frequently. So we have to rule out this is not at the root of this problem.
Next time I will do it.
Yeah.
That means urge incontinence
Bladder is known as urge. Yeah.
Who used to like this whole day she was like incontinent for right now. Sub if you have to see, then finally you had to do a cystoscopy. Still everything all right. Everything. What came was I would pass urine in the night, wetting, and the vagina actually was that collecting in the
Common. It is a common problem.
and when they were walking then it was leaking from the vagina.
It's a common problem.
So this
Yeah,
with
this
young
is
girls and young children,
this
you
is-
start have to think of that
Yeah,
also.
this is called vaginal voiding, especially if the child sits with thighs closed. We have to teach the small girls to sit with thighs quite abducted, open, and at times we teach them to sit on the so that they abduct the thighs very much. Then the urinary stream will not go into the vagina. Vagina being a common problem. After the child goes to, then she keeps on dribbling a little urine which is collected in the vagina. There can be that's out slowly. Another actual problem. These are the functional problems, but there is another problem which is known as ectopic ureter. At times, one of the ureters is opening. The ureter is opening in the vagina. Yeah, but there's one ureter, so she will be voiding normally also. The problem is that the parents will say She voids normally also. This is like ureterovaginal fistula. A congenital ureterovaginal fistula is known as ectopic ureter. The ureter is opening there only. And one ureter is open, the bladder is filled with them. After 3-4 hours, the patient goes to void, good stream, no problem, no pain, nothing. Why she is that all the time? Because one ureter is open in the. And on cystoscopy also, you can see both ureter inside. Then this is a duplication of one duplication system on one side with one ureter going in the vagina, other ureter in the bladder. So these things have to be investigated properly. Yeah, both ureters will be seen inside also. If it is not a duplex system, then you can use only one ureter that is missing. But these two vaginal fistula and congenital ectopic ureter both will have hydronephrosis. These patients are leaking in the vagina, but they are not. These ureters don't freely drain. They have to traverse the perineal flow and.
Because what we saw was 3 or 4 cases which were what came. So each of every case, this video we are going to show you just of each cases which is edited and nicely done. So that tells you all the indications, all the preparations needed for each case. Otherwise you saw no preparation needed, no post-op needed, nothing is needed. Comes in the, we are doing it there, but you can do it in the OPD also. And no, just wear gloves and just, because and you saw the picture of how the holes were looking, and just a mild care of cleanliness which is this. Hi. So, bye. Thank you for all that. Let's see some videos. Whoever. Samir. Or yours, this thing is in this. Your videos are in this. Never mind, we have password.
So this is from the pen drive, and we could open.
Okay.
This was filmed in my clinic, my private clinic, not in theater room. At the demonstration of the procedures, first we go through the
Hi, I'm Dr. Ronen Gold,
family
a urogynecologist. I'm happy to introduce to you Alma Laser's FemiLift.
This is the normal probe, not the smart.
Mounting the classic FemiLift probe. The probe comes with a cover that it's not for use. We have to take it off. And then we connect it to the machine. And we are ready to treat the patient. Mounting the slim FemiLift handle.
This is this
Comes
women
with a
for
cover
never
that we
vagina.
need to remove prior
elderly
to the
patients
treatment.
with no vagina after radiation.
Take a single-use
The probe doesn't fit them, so we
and
have
connect
slim
it
probe.
to the probe. It's very important to ensure that the windows is against the mirror. We connect and we are ready to use. Choosing parameters for FemiLift treatment. We choose the surgical mode, the FemiLift, and then choose settings for energy, power high, medium or low, and mode plus or repeat. It's very before we start any treatment with to inspect the vagina thoroughly, to rule out any infection, any cervical abnormalities, any bleeding that can compromise the treatment. Insert the
This probe
until
we
we reach
have
the
to
posterior
rotate
of the
and
vagina,
move
of the vagina, and we can set When you complete 360 centimeters,
This is manual, but that one is being automatic. That's the old one which you do manually. What you saw there. No, this is
Right now
same thing which did automatically.
is the same probe, but it's done manually. The rotation and the pulling is done manually. In soon we'll see the automatic as we demonstrated. This is the manual probe. Some doctors feel more comfortable with the manual probe because they feel they can handle the control. They have more control on the treatment itself. Some doctors prefer the automatic because it's done automatically. They don't need anything just to hold the probe, which to use. It does the same thing, only here it's manually and there it's automatically. You can choose. And this is a live patient without any local anesthesia.
approaching the introitus, when we start to see the laser
See the blood.
using the mirror, we now reach the introitus, and it's a sign to decrease the energy level, to decrease the pain and sensitivity in the area. And when we finish the whole of the vagina, we repeat the procedure again along the vagina, 306 degrees along the vagina. 3 passages.
At least.
When we finish the procedure,
Because
it's
a much
always
more
important
company, I do
to
it
inspect
at least
again
5,
the vagina with a
because
speculum.
I found that the passages
There are
are
no
much
any-
more effective than 3.
And the treatment is done 360 degrees. Excellent.
Screen. You only need
Cover. Make sure that the windows is against the mirror. And press done. Then we mount the protector on it and push backwards thoroughly to rule out any infection, any cervical abnormalities, any bleeding that can compromise the treatment. In each patient, we have to adjust the length of the probe, the length of the vagina. So we start by inserting the probe and starting to advance it forward to the posterior fornix by pushing it forward. So to the posterior fornix, and that's the length of the vagina. The next step is to push on the set button, the middle button. And the setup of the knife is complete, and we can start by pressing the foot switch.
that's done
The
automatically.
next step is to start the vagina,
In the previous one, you had to do it
and the
manually.
probe
but
pulls
it's
automatically
It's
along the vagina,
everyone should
360 degrees around the vagina.
handpiece is more
Until it
comfortable to
reaches the
them to use.
introitus that was set properly. And now we've completed 3 passages along the vagina, 360 degrees. There are no any complications, and the treatment was done homogeneously along the vagina, 360 degrees. Excellent.
Now this is the femitide. You can do it like
Mounting the femitide handpiece.
with this
We connect the handpiece
heating
to the machine.
the tissues beneath the skin.
We choose the surgical mode, again surgical, and then the continuous mode, and we can start to treat. And we can start by pressing the foot switch. We heat the tissue to 42 Celsius degrees, and by that we induce tightening of the tissue. We use a thermometer to measure the temperature that we designed.
And this is the scanner for surfacing.
Mounting the Laskin handpiece, right toward, and then connect to the machine. And last, the scanner handle. And we are ready to use. Setting for light scan handpiece. We choose the surgical mode, Surgiscan, and then we choose the pattern and the density of the treatment, and then we set the energy level to start, and we are ready to begin the treatment.
It's very important to mark the outer surface that you don't want to pass them beyond these marks. So it's landmarks to do the treatment. Also we can do it perianal. This is the only time that we apply local anesthetic cream before the treatment. Otherwise, we don't need any anesthetics on it. Any questions? Okay. So what are the complications which can occur? Sorry? What are the complications which can occur? Complication? The only complication that occurred to me was the only patient that there's no penetration of the laser beam itself is 200 microns. If you see the difference between the erbium, the scalar CO2, and the PVC, you see the erbium penetrated the most shallower part of the skin, scanner deeper, and pixel much deeper. And the thermal effect goes beyond any scanner or laser can do, and that's how we can pixel CO2 laser.
Dr. Ronen, one thing, there are in the market what is known as RMEV, radio frequency, laser. So what are these three types? These are three different energies used for the same thing?
If you ask me about the frequency, about tightening and like the thermic, it's for thermal effect. I think the pixel CO2 has a much greater effect than the radio frequency can achieve.
You have modalities like radio frequency,
but we have
which
to
and laser.
head comparison.
Head-to-head comparison has not yet been done.
Really wonderful speech, Dr. Ronen. Thank you so much. And everyone about everything we have learned today about the village. We have come to the end of this wonderful workshop, and we now hope we'll be able to manage GynaLift without Dr. Ronen also. He has explained us so well. Thanks once again, everybody, everyone who has taken off time and come here. Thank you so much. Vote of thanks would be given by Dr. Sudha Bansal, President AOGS.
Thank you for inviting me. Today indeed a very memorable day for AOGS and gynecology. Sir, we are greatly encouraged and immensely benefited lectures, videos and live sessions of aesthetic gynecology. Most wanted subject of the today. Dear friends, we also have today with us the nutrition endocrinologist Mr. Prakash. He had a nice discussion. Prevention is always better than cure. My thanks to our esteemed moderator, for the presence. Also big hands to Master of Ceremony for the nice coordination of this CME. Whole staff of Rainbow, whole management staff, Rakesh Dhamin, Elma Medical Private Limited for sponsoring this CME. Thank you very much.
या क्या सोच रहे हैं कल सुबह